This week on the Back Table Podcast.
The treatment shrinks the cancer, typically quickly within days to weeks for most patients with EGFR mutant disease. So that's a very positive aspect to their care. And then again, focusing on the reality that we can have durable benefit for these patients. And that's what we're hoping for each individual.
Welcome to Back Table Tumor Board. My name is Kate Baker. I'm a medical oncologist and medical director of value-based care at Tennessee Oncology. Today's episode is going to be focused on bispecific antibody use in lung cancer, and we have our guest, Dr. Wade Iams, here. Dr. Iams, do you want to go ahead and introduce yourself and give a little bit of background about your expertise?
Yes, I'm Wade Iams. I'm in thoracic medical oncology. I'm the director of lung cancer research at Tennessee Oncology in Nashville, Tennessee. I do clinic 2 days a week, and then the rest is clinical trial administrations, meetings, trying to keep my ear to the ground, what's going on, all new things in lung cancer.
Awesome. Well, thank you. Well, let's get started and maybe just talk about why lung cancer has become a major focus for bispecific antibody development and what sort of bispecifics we're using in current practice in lung cancer right now.
So the first bispecific to hit practice in patients with lung cancer is amivantamab, an EGFR MET-directed bispecific antibody for patients with non-small cell lung cancer. There's actually recent exciting news in that initially this IV formulation, which has higher rates of infusion-related reactions, and there's a more recent sub-Q formulation that just got full FDA approval within the last month. Previously, that had been on a manufacturing hold with the FDA. So I'm very excited to see the continued rollout of subcutaneous amivantamab. There are a multitude of additional bispecific antibodies in clinical trials for patients with non-small cell lung cancer. I won't list them all now, but I can think of probably a handful off the top of my head, including that we have in clinical trials here at Tennessee Oncology. The reason is there's particular observation that when we approach therapeutic targeting with bispecific antibodies, the proximity of the targets within our therapeutic molecule seems to add some efficacy, ultimately resulting in better patient outcomes. And it's a concept that I've thought about many times. I don't have a clear mechanistic reason why that is, but take the seminal example of PD-1 VEGF bispecific antibodies. The big one you may have heard about is this one moving along the pipeline called Iams. Why is that different than using a VEGF-directed antibody and a PD-1 antibody separately? There does seem to be some synergistic effect of putting your targets within the same antibody molecule. So we're in the process of evaluating that in patients in clinical trials now, and time will tell the ultimate success of bispecific antibodies in lung cancer more broadly.
Awesome. Thank you. Let's go back to the data that got approval for amivantamab, the MARIPOSA trial. How can real-world clinicians like community oncologists interpret that data and apply it to their real-world patients? Is it truly better compared to osimertinib, the EGFR TKI? How do you think about that?
Yeah, so currently in upfront metastatic non-small cell lung cancer, patients with typical EGFR mutations or even our uncommon EGFR mutations that are still potentially targeted with osimertinib, we have two regimens that have been proven to improve average both progression-free and overall survival ultimately compared to osimertinib monotherapy. That's our so-called FLAURA2 regimen of platinum doublet plus osimertinib, and then the MARIPOSA regimen, amivantamab plus lazertinib. So we now have two regimens where we can offer patients improved average survival expectations. Of course, in both situations, that comes with added toxicity. I think we're all familiar with the toxicity that platinum doublet involves in the EGFR regimen. Patients got 4 cycles of platinum doublet followed by pemetrexed maintenance for an average of 9 months. Amivantamab and bispecifics as a whole are really a different entity compared to traditional chemotherapy in terms of side effects. So they don't have the same cyclical fatigue and cytopenias that you run into with most chemotherapy. Many of them do have some GI side effects, often not as severe as chemotherapy, but they have unique side effects is the way that I think of it. Amivantamab, in the case of patients with EGFR mutant non-small cell lung cancer, the unique toxicities that we have to think about there are infusion-related reactions, primarily for the IV formulation, but something we'll have to prophylax even in the now fully approved sub-Q formulation. DVT-PE risk, so anticoagulation for the first 4 months, is recommended with initiation of that MARIPOSA regimen, as well as dermatologic side effects. And it's beyond what we're used to with osimertinib skin toxicity. These are more severe rashes that occur on patients, usually in the face or scalp. There's very involved skin regimens that have been developed to accompany amivantamab. And more recently, I've had some success in patients who are able to be compliant with a more rigorous derm care regimen to really reduce the skin toxicity associated with it. But in some, when we're starting a new treatment for patients with metastatic EGFR mutant non-small cell, we now have 2 options to improve the average survival. I think basically all patients should be presented with those options and have a discussion of the risks and benefits. What does the more aggressive or combination regimen look like on a day-to-day basis, and how will that impact the patient's goals in terms of quality of life?
Well, how does CNS disease play into all of this? What sort of efficacy do these agents have on CNS disease? Because we know that many patients with non-small cell lung cancer or lung cancer in general develop brain metastases.
That's a very important point for all new therapeutics, especially in lung cancer, where, as you noted, so many patients develop brain metastases. So we have good data from both the MARIPOSA trial looking at amivantamab plus lazertinib and FLAURA2 of chemo plus osimertinib that we know these combination regimens control brain metastases better and for longer than using osimertinib alone. And osimertinib is good at treating patients with brain metastases. I was certainly try that without instituting radiation for patients with small asymptomatic brain metastases. So we know that both the bispecific antibody in the case of amivantamab and chemotherapy seems to add something in terms of CNS efficacy. I think the reality is what we're learning with bispecific antibodies especially is that while historically we had been of the opinion of if the drug mechanism is such that it's unlikely to cross the blood-brain barrier, then the drug is not going to have any CNS efficacy. But what we've learned more recently from clinical trial data, speaking for itself, is that the blood-brain barrier is not intact in patients with brain metastases. And so I think the way that I think of these new drugs is with a non-intact blood-brain barrier, we now have opened the door, though, for more potential for the newer therapeutics, including bispecifics, to offer some CNS efficacy, which ultimately is great for patients. We have to be very mindful and work with our radiation oncology colleagues, but it's certainly an area of data that we have to follow with the new drugs.
That's super interesting. When you're seeing a new patient with EGFR mutated non-small cell lung cancer, how do you counsel patients on prognosis and response rates to these agents, like in real world use?
Important question. So I do typically approach a prognosis discussion first assuring patients want to hear certain numbers like average survival. And there's a lot of discussion in the field about whether quoting average survival is appropriate or whether landmark survival time points can be used and phrased in a potentially more hopeful fashion. But in short, what I do in clinic is ask patients if they're interested in hearing what the average survival is. And 9 out of 10 patients are, just for planning purposes. So when we think about the average overall survival for patients with EGFR mutant non-small cell lung cancer, what we've seen is an improvement by 10 to 12 months with both of these combination regimens. So amivantamab and lazertinib, as well as chemo plus osimertinib, improve the overall survival by close to a year or more compared to doing osimertinib alone. And so I will typically quote those numbers for planning, but What I don't do is dwell on those numbers. Then I usually quickly pivot to what we're hoping for. And what I certainly have seen is patients having years-long durable disease control, even with stage 4 disease. And the reality of those conversations, not unlike when a patient's first diagnosed, is that if you've disclosed the average number, that will be what sticks in their mind. They know that it'll be kind of forever burned into their mind. So you don't dwell on it, in my opinion. But you focus on what we're hoping for, take it scan by scan is the way I phrase it, moving things forward. The treatment shrinks the cancer, typically quickly within days to weeks for most patients with EGFR mutant disease. So that's a very positive aspect to their care. And then again, focusing on the reality that we can have durable benefit for these patients. And that's what we're hoping for each individual.
That's great. And then when you're thinking about sequencing chemo, a platinum doublet plus osimertinib versus the amivantamab bispecific antibody plus lazertinib, how do you choose between those two in a patient with a new diagnosis? And is chemo plus osimertinib an option if you start with the bispecific antibody in the second line?
Really good question. So the short answer, I'll take the second part first. Chemo is absolutely an option if you start with the bispecific upfront. As far as choosing between the two, what I'll boil it down to is pretty direct. When we only had IV amivantamab plus lazertinib, my leaning was towards platinum doublet plus osimertinib, just because IV has significantly higher rates of infusion-related reactions. Now that we have the sub-Q commercially available, and I'm still working on ironing out that if we can now order this sub-Q in the clinic and get it for our patients in a very timely fashion. So we're still ironing that last piece out. But I would actually then trend towards subcutaneous amivantamab plus lazertinib as the preferred initial approach. I think that we can manage those unique toxicities. They're distinct from chemotoxicities, and ultimately we can still use chemotherapy in the next line of therapy. If you use platinum doublet plus osimertinib up front, the reality is the median progression-free survival from those clinical trials is around 2 years. So your platinum will have been essentially off board on average for over a year for most of those patients at the time they progress. So in my opinion, even if you start with platinum doublet plus osimertinib, you could go back to ami plus chemo if a patient could tolerate it in the second line, if you're on a track where you want to be as aggressive as possible for all treatment options.
Great. That's helpful just to think about how to manage these patients and counsel them to help them choose upfront treatment for EGFR mutated non-small cell lung cancer. You bring up an important point about the logistics of the subcutaneous amivantamab. Can you talk about some of the challenges that we're seeing right now in terms of getting that into clinic with that new approval? And then maybe let's go into more specifics about how we manage those toxicities that we're seeing, particularly the dermatologic and other toxicities.
Yeah, absolutely. So what's happened with actually 2 recent lung cancer drugs is a manufacturing hold by the FDA, where the FDA will approve a drug based on efficacy. And in the case of amivantamab, that's our gold standard, improved overall survival compared with standard of care. But the FDA had initially cited that they weren't confident in the manufacturing and distribution plan of subcutaneous amivantamab. I don't know the full details as to why that was limited, but in that circumstance, the same thing also happened to patritumab deruxtecan, or HER3-DXd in lung cancer recently, as an aside, whose label has now been completely withdrawn because of a negative trial comparing that to platinum doublet in our EGFR mutant patients. While I still think it's a very intriguing drug and disappointed with the label withdrawal, that's to say amivantamab is not the first drug where manufacturing hold has been placed. But as I said, just within the last month, that manufacturing hold has been removed. But to me, that has caused uncertainty as to how quickly that means we can roll out subcutaneous amivantamab in the clinic. So we have to make sure that our pharmacy capabilities can acquire this rapidly. And to me, it's a case where until I've gone through the process once, there's not a good way for me to confidently say that I can get this quickly for my patients. You can be told by any number of people, whether it's from the company or from your internal practices, but ultimately we've got to do it. And I'm looking forward to my first time doing it for the commercially available subcutaneous formulation. And once we secure that, I think it'll be very straightforward moving forward. I wish I had more insight into what the manufacturing hold was all about, but it has introduced uncertainty in the field. But the biggest thing to iterate potentially from today's call for all of us in our practices is it's now fully FDA approved, amivantamab subcutaneous. So let's work with our teams, make sure we're aware of that, and we're able to effectively roll that out into the clinic.
Great. And then just regarding the toxicities, can we go into a little bit more specifics about, because you mentioned with the dermatologic toxicity, some specific prophylactic medications or topical agents that you'll use. Can we go into a little bit more detail about that?
Absolutely. And in my experience, compliance with that regimen is key. I actually have a patient on the Copernicus clinical trial, which up until the subcutaneous formulation was recently fully approved, the only way patients could access subcutaneous amivantamab in the US. And so that patient actually just had a near complete response on his initial scans before Christmas and has had no derm toxicity. And he's very compliant. Now, what that entails for the derm regimen is daily doxycycline for several months after you initiate amivantamab plus lazertinib, as well as chlorhexidine. It's just nail bed rinses, but daily chlorhexidine rinses. And then there's specific criteria you'll find in the label for a skin moisturizer. So using a moisturizer daily, your chlorhexidine rinses, your doxycycline, and then the chlorhexidine rinses after 3 months change over to clindamycin topical use after that time point for the derm prophylaxis. So it's a little bit complex, but I don't think too far of a stretch, and it's certainly achievable for most of our patients. It's going to take some counseling. J&J has great resources as far as, single page handouts to walk people through this, as well as for our teams. And what we've done at Tennessee Oncology, and I would certainly recommend, is for our standard of care regimens, just build the whole regimen in with the treatment plan, so that we're not having to place additional orders for doxy and chlorhexidine and our moisturizing skin lotions separately. Just a package deal. If we're ordering amivantamab plus lazertinib, add the anticoagulation there, by the way, as well, and just make it as easy as possible. But there were a few patients of mine who had bad derm toxicity before, the more recent patient, and I think they did struggle with complying. And I think some of that was on me and our clinic staff of communication. So you can have the orders in the chart, but if a patient doesn't understand what they're supposed to do every day and is not able to execute that, then it's really not fully compliant.
Sure, that makes a lot of sense. And then just small question, in terms of anticoagulation for DVT prevention, is there any specific agent that's preferred, or it's just clinician's choice?
Within the label, I do think it's apixaban, 2.5 milligrams twice a day. I certainly personally wouldn't have a problem of rivaroxaban if, there was a cost issue with apixaban and rivaroxaban. I think we know sometimes we run into cost issues with patients, or even a prophylactic dose of Lovenox if that ended up being the cheapest and something the patient was willing to do. But any prophylactic dose of anticoagulation would be okay, in my opinion, from a clinical perspective, although the apixaban 2.5 BID is the label accompaniment.
That's super helpful. Thinking about future directions in non-small cell lung cancer, I think we've mentioned a couple of things that are currently in trials, but is there any particular direction in bispecifics in non-small cell lung cancer that you're most excited about?
Oh, yeah. So certainly in terms of what has gotten the most press, it's going to be our PD-1 VEGF bispecific strategy. The lead compound among the companies is ivonescimab. That's shown notable improvements so far just in PFS, in upfront metastatic non-small cell lung cancer patients. So far, the data is heavily from China, although they're enrolling more patients in the US, including us. We've just opened our first ivonescimab study at Tennessee Oncology. So that's gotten the most attention. There are other companies that are developing PD-1 VEGF bispecifics, and I think it's a very interesting field to follow, because I had always thought of VEGF in lung cancer as, yes, it adds small marginal benefit. In the immunotherapy era, that small marginal transient benefit that VEGF inhibition added was dwarfed by the potential benefit of immunotherapy as a whole. And now that we've had immunotherapy really pervade in the form of immune checkpoint inhibitors, I should specify, because there are newer forms of immunotherapy such as BiTEs that are very intriguing, making huge waves in small cell lung cancer. But at least immune checkpoint inhibitors have kind of pervaded and set their place within the field. I do think it's a time to reevaluate the addition that VEGF can add to our therapeutic armamentarium in non-small cell lung cancer. And I think it will add something. The question is, how big of a benefit is that going to be? So PD-1 VEGF is the main one that I would recommend following for the time being, but there are a host of other bispecific antibodies in development. Just to name a few, looking at combination checkpoint inhibitor bispecifics, like targeting PD-1 and CTLA-4 at the same time in the same molecule, targeting PD-1 and TIGIT at the same time with a bispecific antibody. So there's an EGFR LGR5 bispecific antibody that's made some good headway in patients with head and neck cancer as well. So various strategies looking at that same fundamental mechanism of the making the targets in close proximity with a bispecific antibody. And I think it's an interesting time in the field to see all those data sets evolve.
That's awesome. Very exciting time. Well, you mentioned BiTEs, so maybe we should talk about tarlatamab in small cell lung cancer now and shift gears a little bit. Can you talk about the current data for use of BiTEs in small cell lung cancer, tarlatamab being the one that we're primarily using?
Absolutely. And it's been such a fascinating story with tarlatamab, where tarlatamab has kind of been the golden child, if you will. Every setting and data set that we've seen with tarlatamab, which is a DLL3 and CD3 directed bispecific T-cell engager, it seems like everything has been positive. So of course, it initially started in patients with relapsed small cell lung cancer. The first data set that led to tarlatamab's FDA approval was actually in third line small cell lung cancer. And it was approved based on significant median duration of response of between 9 and 10 months in the third line setting. Third line small cell lung cancer patients, you can make a case, are a little unusual, not very common for patients to live that long to get a third line therapy. Nonetheless, even in that population, there was a median overall survival of 14 months. So that led to FDA approval, and the FDA initially approved tarlatamab in the second line based on how compelling the third line study results were. So there was a lot of interest, and certainly for me, and I think healthy skepticism about what a second line test of tarlatamab would look like. So that was data that just came out at ASCO last year, looking at tarlatamab in second line small cell lung cancer compared to dealer's choice chemotherapy. And their median overall survival was improved by about 5 months. So from about 8 months with standard of care chemo to up to 13 months in patients who were treated with tarlatamab in the second line setting. So really a resounding victory for tarlatamab, even in the second line. That led to full FDA approval of tarlatamab in the second line or later setting. Initially, it was just an accelerated approval, rightfully so. Amgen has seen the promise in tarlatamab and continued to move this drug up further and further upstream in the treatment paradigm. So the most recent data that's coming out for tarlatamab is showing very promising results, adding tarlatamab either after induction chemoimmunotherapy, just in combination with the checkpoint inhibitor, or even as early as the second or third cycle of induction, adding tarlatamab for patients with extensive stage small cell lung cancer, showing very impressive survival rates that are still early in clinical trials, but we're talking median overall survivals of over 20 months for this extensive stage small cell patient population who just 2 years ago, our median overall survival was 12 to 13 months. Now, those data sets still need to mature, and 2026 is going to be a very interesting year to follow the data updates for tarlatamab in the upfront setting in patients with extensive stage small cell lung cancer. But I personally do think it's headed there to the upfront setting.
Wow, that's, truly incredible data for this patient population that previously had a pretty poor prognosis after upfront chemotherapy. So that's great. Let's talk a little bit about the specific toxicities of BiTE therapies, because my understanding is right now in most places, these agents are requiring admissions for at least the first few cycles. Can we talk about the specific toxicities, the ICANS, the CRS, and how you think about that? And is there an opportunity potentially to take out those hospital admissions in the future?
Yes, that's the million-dollar question. So the main two immune-related toxicities that are unique to BiTE therapies as a category, CAR T therapy also has that. I'll just actually start that little phrase over. Absolutely, it's critical to talk about the toxicities associated with BiTE therapy. The main toxicities are cytokine release syndrome, or CRS for short, and ICANS, which is an immune-mediated neurotoxicity syndrome associated with confusion and decreased level of consciousness. I think it's important to remember that CRS is actually the most common toxicity that the patients have experienced on the tarlatamab studies. So these are black box warnings, but not a black box warning that's, less than 10% of patients. This is the most common side effect that patients experience when treated with tarlatamab on clinical trials. CRS is defined as fever and any degree of hypotension or hypoxia that can accompany that fever, and is really, as you suspect, a significant immune activation that can occur when, by the drug's mechanism, you bring the T cells into direct proximity with the tumor cells. That's going to stimulate an immune response. So the current label for tarlatamab requires observation in a so-called appropriate healthcare setting for 22 to 24 hours after the first 2 doses. It's been shown that that's the significant risk period for CRS for patients treated with tarlatamab. That's because it's the first time they're encountering the drug with a 1 milligram step-up dose on the first day, and then a 10 milligram full dose on the second dose, as long as they've tolerated it and continue to move forward with treatment. And then it's just 10 milligrams thereafter. So really those first 2 step-up doses require the observation accompanying it, and CRS rates are a little above 50% in clinical trials for those patients. ICANS rates, on the other hand, are generally less than 10%, generally more delayed in onset, whereas CRS typically occurs within an average of 12 to 14 hours after the dose. ICANS occurs on average 30 days after the dose, so it's hard to pin down exactly which dose leads to ICANS when it does develop. But CRS we know, and the CRS monitoring is what has prompted the more strict label. There's some data, we could talk about additional questions too as we go along, but the label may evolve is what I'll leave at for now if we want to go down that path next.
No, that's great. How often are you seeing grade 3, grade 2, grade 3? Like what's the typical course for CRS? Is it pretty mild, or are you seeing more severe side effects?
At Tennessee Oncology, it has been predominantly mild, and so just a quick rundown on grading, just because I'll use that jargon for our experiences within Tennessee Oncology. Grade 1 is fever alone without hypotension or hypoxia. Grade 2 is fever plus any degree of hypotension or hypoxia beyond baseline. Grade 3 is already to ICU level severity, so fever plus hypotension requiring a pressor, or hypoxia requiring more than 6 liters nasal cannula, so immediately to very severe. So I believe we've had just 1 patient with grade 3 CRS within Tennessee Oncology. Probably 30 to 40% of our patients have had some CRS. We've had a pretty low threshold to administer tocilizumab. You can also use dexamethasone to reverse CRS. And then ICANS, it's just glucocorticoids, so either dexamethasone or IV methylpred for reversal of ICANS. So with our threshold for tocilizumab, we've administered it for any concern for even approaching grade 2 CRS. So it can be a soft call of what's new hypotension, what's new hypoxia, and we've administered tocilizumab quickly for our patients who experience CRS for the most part, and only one of our patients has required repeat doses of tocilizumab. So it generally is neutralized quickly, and at least extrapolating from the CAR T literature, we don't think that aggressively treating CRS is going to reverse the anti-tumor efficacy. That's what we're most concerned about, of course, but in short, it's been mostly mild CRS. We have taken a more aggressive approach to tocilizumab administration for our patients, but we've been able to keep patients out of trouble and no lethal side effects.
That's great. As we think about getting these out into the community, what sort of tools are community oncologists, especially in rural areas, going to need, and what sort of education will need to be provided to hospital partners in those areas?
Absolutely. I think the most important thing that comes up in the debate of how quickly and how far can we roll out tarlatamab to the outpatient setting is access to tocilizumab, our IL-6 antibody that can help reverse CRS. And so understanding where you can access that, what's the closest hospital to do that, I think is the key first step in any community, especially in a rural setting, to being able to approach outpatient tarlatamab. But the other reality that dexamethasone can manage patients with CRS as well. We don't have prospective data saying that tocilizumab is more effective than dexamethasone, but you do have to recognize it and have patients take dexamethasone quickly. So what we recommend at Tennessee Oncology is patients have a prescription for dexamethasone on hand at home as they start tarlatamab, even after their observation period, so that if they call in with a fever, have our triage team tell them take the dexamethasone that they have at home. Start that immediately, because that may be key in reversing the syndrome quickly. But getting into local hospitals, both ERs and intensive care units, also the floor teams, are going to have to recognize this, because the patients are going to look infected, they're going to look septic, and they have to have within their repertoire that this could actually be their cancer treatment causing it, and they may need repeat doses of dexamethasone or tocilizumab if it's available. So I think that the key pieces in how extensively we can roll out tarlatamab in an outpatient setting and more rural settings is going to be contingent on, yes, do we have tocilizumab access, at least knowledge of what that pathway looks like? What are the hospitals where we can get that? Can we deploy dexamethasone as readily as possible in the meantime, have our systems primed for all patients to be able to start treating their CRS and potentially ICANS as soon as possible? And then can we equip our systems? Do we have collaborations with at least a local hospital where maybe we can have good communication with the ER, the ICU especially? If these patients are coming in the front door, how can we recognize them and get them treated appropriately with immune suppression as quickly as possible? I would also add, I think it's very reasonable to treat these patients with antibiotics too. They have advanced cancer, they may have infection. That was certainly observed on the clinical trial. I think it doesn't feel great when you're in the inpatient setting to use both steroids and antibiotics, but sometimes that's what we have to do for these patients to make sure that we're just controlling the reaction that they're experiencing.
I think that's super helpful, just thinking about how do we expand access to these agents, because at least in my experience, the number one complaint from my patients as a person that's practicing 30 minutes outside of downtown Nashville is, I absolutely do not want to go to downtown Nashville and get admitted to the hospital. So personally, I'm very excited about the possibility of rolling out these agents to the outpatient setting and working with our hospital partners in the area.
Yeah, I think we can do it. We have to have a low threshold. That's what I've certainly learned with our process at Tennessee Oncology and from our malignant hematology colleagues. A low threshold to treat fever in these patients. Be very aggressive and make in terms of your proactive communication, and then execution if and when they do have a fever.
That's awesome. Well, given the success of tarlatamab in small cell lung cancer, what do you think next steps are? Other BiTEs or bispecifics in small cell lung cancer under development? Are we going to be using this earlier and earlier, as you mentioned, in treatment of small cell lung cancer? What do you think?
Oh, yes. So tarlatamab, in analogous fashion to ivonescimab in the case of PD-1 VEGF bispecific, tarlatamab is not the only DLL3 CD3 bispecific. There are other agents in development, rightfully so, that are expanding indications, looking at all neuroendocrine tumors which have high DLL3 expression, which are moving into the limited stage setting. I'm hopeful for those clinical trials in that future where we may be using bispecifics even in earlier stage, bispecific T-cell engagers, that is, even in earlier stage small cell lung cancer. So I think other agents in small cell that are in development that are intriguing. There are also tri-specific T-cell engagers that are really trying to build on the momentum of bispecific T-cell engagers. Sometimes, they'll add additional binding to albumin to extend the half-life of the drug within the patient, and then your CD3 plus DLL3 targets as well, but other undisclosed tumor antigen targets being evaluated in the clinic. So it's a very exciting time for T-cell engagers, whether it's bispecific engagers or even tri-specific engagers. There's a lot of activity in early clinical trials. For now, it's broad in the bases that are being evaluated in early clinical trials. And so over time, we'll have some refinement for lead indications, lead histologies as these new bispecifics and trispecifics come along.
Awesome. Thank you so much for your expertise. I think this has been a really helpful discussion. As somebody who's a general oncologist that sees a lot of lung cancer patients, I'm really grateful for your expertise and the discussion we've had today. So thanks for your time.
Yes, thank you for having me, Dr. Baker. Appreciate it.
Thank you so much for joining us on Back Table Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _backtableonc, that's _backtableonc on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.